Good Friday morning, friends. We once again have a lot to cover, so I'm going to jump right into it. And we're going to start with some state updates. Um, I like to start with this because it's many of you have been consistently acting and engaging with both state and federal policymakers for the entirety of this year. It's hard to believe that it has been almost a year of us doing these weekly webinars. And this is a great reminder that advocacy is always a long game. Back several sessions ago, probably 6 to 8 years ago, disability advocates decided that they were going to change their special education ask, that we were no longer going to negotiate for what is the smallest increase that we thought lawmakers would accept. And we said, you know what? These are mandated services. Schools have to pay for them, and private schools are allowed a 90% reimbursement rate. Why aren't we asking for the same thing? And by the way, it also should be a sum sufficient appropriation. So even if the estimates are a little off, the money is there to cover those services. And I actually used to joke, except I wasn't really joking, but I said it in a tone that made it seem that way to some legislative staffers, that I was actually giving them a discount by asking for 90%, because of course, if we were to cover actual costs, it would be 100%. We were laughed at. And in fact, some people got a little angry with us because they didn't think that what we were asking for was possible. But we kept asking. 4 years ago and this session, education advocates, more of them, there were some education advocates that would agree with this ask, came on board and said, you know what, that is the right ask. And you know what, some sufficient funding is a good policy idea, because we keep getting into this situation where the legislature appropriates money based on old estimates. And by the time our school districts are submitting their actual bills, the amount of money that the legislature set aside isn't enough to pay those costs. And what they promised becomes actually a much lower reimbursement rate. And so we talked to the Department of Public Instruction, and they changed their ask to be sum sufficient. So it just shows you that sometimes, like water dripping on a rock over many years, the thing that starts off as being impossible becomes the thing that is possible. And the last couple of weeks, we have talked about how the same problem that we have seen in other sessions has happened again. This budget cycle, we got a bigger increase in the reimbursement rate from the legislature than we have in many years. And yet, because the legislature set aside some certain amount of money, the same problem has happened where they used old estimates and the actual costs are much different. So the amount of money they set aside is not enough to keep their promise that they made in the budget. And it means about $140 million less for special education than what school districts thought they were going to get in the summer. Now, there is a bill introduced, and it is a bill that is saying we want to change the appropriation to sum sufficient for special education. And we want to do that so that the amount that was promised, 42%, that's 42 cents for every dollar, actually gets to schools. It's the first time we've seen a bill language that has made that ask, right? So this is actually a big movement. We went from you folks are asking for something that's impossible to making it the mainstream ask of a much wider group of advocates, to making it a legislative proposal that is being asked for all members to sign on to it. And it's another opportunity for advocates, because now there is something you can point to when you are engaging with your state legislators, not only to talk about what it means, when schools don't get the amount of money they need for special education and what it means when they get less than they were promised, um, and what it means to students with disabilities who suffer the consequences. But you also have a way to ask and say, hey, have you seen this proposal? It doesn't have a bill number yet. It's still circulating for co-sponsorship, which means that legislators are being asked if they want to put their names on the bill. And generally, when a legislator puts their name on the bill, it's kind of a nod and a signal that they support the idea. And when many legislators, especially many legislators of both parties, put their name on a bill, that is a sign of strong support for a bill. And it's an opportunity, again, for advocates to know who is and isn't on the bill and who is saying they support the idea or not. Legislators have until the close of business Monday to add their names. So if you are looking for something to do with your weekend time, this is an opportunity to kind of reemphasize the importance of special education. And for many of you who may have advocated very hard in the state budget process this spring to say, hey, at least come up to the level that you've promised. Another thing the legislature has done, which is directly related to the changes we've been monitoring all year from the federal H.R. 1 bill, they have not yet approved the additional money that the Department of Health Services says it needs to meet the new requirements for the SNAP program that have been implemented as a result of H.R. 1. So the legislature has chosen not to act. The department says it needs about $70 million more because changes that went into effect both in October and in December are already in place. And that means that there are many more people who must now prove that they are working or exempt from SNAP working requirements. And Wisconsin needs more people and better systems to process and track all of that extra paperwork that is going to come with many more people having to do more things. Many folks in our community may be in the exempt population and may already be categorized as being flagged as exempt. However, all of us know that whenever you have lots more paperwork with the same amount of people and the same systems to do it, not everybody who needs to get through the door can do so at the same time. So even for people who are exempt from the new requirements, making sure that the systems and the people are in place to process that in a timely way is really important to make sure that people who are eligible for food assistance can access it and get it without delay, and also get the help they need, because sometimes there are people who are applying that need some support to be able to figure out what to do. And you need people to help folks do that. So the Department of Health Services has been pretty clear, and I think the legislature understands this, that January is really kind of the point of no return, that it takes time. After you get some money, it takes time to hire people and to make system changes and to train folks and to kind of get these changes really implemented. So in January, we are going to be in a place where the state is going to start to have to count more and more errors because we don't have the resources in place to be able to make sure that we're doing we're meeting the new requirements that the federal government has. And those errors matter because states end up getting financially penalized if they have too many errors. So the longer it is that the state doesn't have the systems and the people necessary to meet these new changes, the more likely it is we will end up being penalized financially and have to pay a lot more if the state is going to continue to operate SNAP. One of the changes in HR1 was to require states to pay a match in order to get federal money if they based on their error rate. And we have some content much later in the presentation that will cover about how many states may not be able to do that, and that it may in fact threaten the many states from participating in the SNAP program at all. So this is an important thing that has not happened. And certainly hunger advocates have been asking for our state legislature to move forward on this since August. I expect we will have some more updates and maybe action steps next week. Another issue, we got asked a question about this, and Sally is kind of working on real-time updates here. But some of you have asked questions about Division of Vocational Rehab funding. This is another sign of just how many federal programs people with disabilities are touched by, and how important they all are as a network of support to be able to help people with disabilities and families kind of find a path and a way to participate in the community as much as possible. Like Medicaid, the Division of Vocational Rehabilitation Funding is a federal state matching program. And that means that the state puts in a certain amount of state money in order to get a lot more federal money. And I forget what the ratio is, but you put in a certain percentage, say 40% state funding, and that enables you to draw down 60% more in federal dollars. This year, the 2-year state budget, again, didn't provide enough money to cover the costs of everyone who now needs DVR services. The legislature set aside the amount they thought would be enough, and it isn't enough, partly because the demand for those services, the people wanting to figure out a pathway to employment has increased. And that isn't necessarily reflected in the estimates that the legislature was working with. Because there are more people who want services than there is money to provide them, the Department of Workforce Development has created a wait list. We've talked about wait lists in the context of Medicaid. This can also happen with other programs. And until about 10 years ago, there was a wait list in DVR. Actually, in another example of asks that advocates made for which they were yelled at, we did some work more than 10 years ago to say, hey, this wait list is here because the state isn't contributing enough money. There's more federal money that we could draw down to do more stuff, but we have to increase the amount of money the state is putting in. There was a wait list for DVR. And the legislature listened at that time. Under Governor Walker's administration, it was one of his budgets that increased the amount of state funding to DVR and ended the wait list for those services. So we haven't had a wait list in about 10 years, but it looks like, we are again in a situation where now we don't have enough money to be able to fully draw down the amount of federal funding that's available. So the wait list really means that the department is now prioritizing who gets served first. It's called an order of selection, and it means they serve the people with the most significant disabilities first. There are 3 kind of stages of that, and there's a frequently asked questions document that shows you how it works. It's unknown how long people will have to wait. However, it is also clear that waiting has consequences, and there's a connection between a lot of transition programs in schools using DVR services as part of the supports that they're providing students as they're trying to explore, what are their options after high school. So this is a thing that has a larger ripple effect and impact. And what we have been trying to figure out is how much money does the department need to fully serve over the rest of the biennial period, um, the people that they think that are coming through the doors who are now being told to wait. We do not have that number yet. And we have said to the department, like, it's really important for advocates to know and to communicate with the legislature very directly about what is it that is needed in order to help the legislature understand what to do. We've talked about this bill before, and I won't spend a ton of time on it, but it is a bill that really is fundamental about who makes decisions. And if it isn't the person themselves, at least from a disability point of view, that can, lead very quickly to decisions being made about somebody without their consent and not really necessarily the decisions that person wants happening. So the people that this is still a good opportunity for people to engage with legislators and really say, hey, we are following this bill. There is a growing list of advocacy organizations and outside of aging and disability that are pointing out and finding some of the same issues with the bill that are concerns for many people who are older adults and people with disabilities. And I've kind of left some of those things there. We also talked about a bill last week, AB 308, that would have prohibited state or federal funding from being used to provide health care for unlawfully present individuals. And we covered a lot of the reasons why, the questions that come up if you were actually to implement that policy. It would essentially mean a pretty wide group of, funding sources that people use for healthcare would be impacted, and that, if you're saying that unlawfully present people can't use those payment sources, that means kind of everybody has to prove that they're lawfully here. This bill was vetoed, and the governor's vetoed message was more focused than the very broad array of concerns that advocates kind of laid out as being potential impacts. Importantly, he said what we have been saying for the last year, that, already people, especially who are in Medicaid, that undocumented people and people who are not legally entitled to receive Medicaid don't get it. So once again, it was a message that was very clear of this is not a law that is necessary because our existing laws and practice already prohibit people from being in the programs that like Medicaid. And over the past year, we have, consistently heard many, many elected officials trying to claim that there is a lot of fraud, waste, and abuse in public programs like Medicaid, when that is not borne out by the facts. That is not the case. Congress. So here's our timeline. It's a pretty short timeline. We had this week where Congress could do stuff, and next week is the last week that Congress is scheduled to be in session for the remainder of this year. They are going on a holiday break after the 18th. So next week we will have our last webinar of a year to kind of cover what they decided to do and not do. What has happened here? Most of the attention has really been on the expiring ACA marketplace subsidies, which will expire as of January 1st. December 31st is the deadline when those subsidies expire. And if they expire, then the subsidies go back to what they were in 2010. I've highlighted here 60 votes in the Senate because that is, in fact, the number that is important. Um, we have a number of ideas that have been floated in both the Senate and the House. The Senate has taken some actions this week, which we will cover, and the House has not formally come up with an introduced plan um, to either address the subsidies or an alternative or healthcare in general. There's some discussions actually this morning about what they might vote on next week or not. Um, but even if the House votes on a proposal that, say, has the support of both, maybe it isn't a proposal that only Republican votes send over to the Senate, even if they have a proposal to do something like extend the subsidies as they are, that has enough Republicans and also Democrats supporting it, it still has to be able to achieve 60 votes in the Senate. And at this point, the Senate has voted down a clean extension for the ACA subsidies, I think 16 times. So it looks fairly unlikely at this point that there will be a magic solution in the next 3 days that would keep things exactly as they are right now. So here's what the Senate did this week. As expected, they voted on the Democrats' plan, which was a condition that the Democrats had as part of reopening the government to have a vote on the subsidies. And the Democrats' plan was to extend the current subsidies as they are now for 3 years. It failed. It was expected to fail. The Senate Republicans did choose to put up an alternative proposal, and they had a bill that would essentially end the subsidies and redirect the money that would have been spent on subsidies into individual health savings accounts. That vote also failed. So the Senate had two votes on two very different ideas, and neither of them had enough support to pass. House Republicans have been saying we're going to release our plan for more than a week now. They had meetings last week. They met over the weekend. They met earlier this week. And the best they could do is come up with a PowerPoint that listed 10 different items, some of which are familiar, like the health savings account idea, none of which were extending the subsidies as they are now, and some of which were very brief. Like one of the bullet points on that 10-point list was innovation, which could mean a lot of things. This morning, House leaderships is deciding, do we want to vote on anything next week? They could do nothing. That is an option here. The moderate House Republicans would like to see some extension of the subsidies, largely because they are worried their voters will not tolerate the subsidies expiring and their premiums going up. That is not a clean extension of what we're doing now. It would still have policy changes unknown because nobody's seen the language, which could change who is eligible for the subsidies and how much those subsidies are worth, and other things that are different from what we're doing now. And if you have attended these webinars before, you know that states can predict what it means for the subsidies to expire and what it means for the current subsidies to continue as they are. And anything different than that becomes very, very hard to calculate what it means for individuals' premiums. So in November, it was already becoming almost too late for states to be able to adjust, if there were changes made to how the subsidies work, to adjust how they calculate what it means for individual plans so that people who are shopping for plans would know what those changes actually meant to their coverage and to their premiums and to their out-of-pocket costs. Now we are 3 days away from when most people have to make a decision on a plan. So we really are at a place where if it is anything different than what we're doing now, it is too late. And it was too late almost in November, and now we are in, the second week of December. There's also a bill that the House has been working on that is a similar idea to what the Senate just voted on yesterday. Again, an idea about ending the subsidies and redirecting the money into health savings accounts. So here's the dynamics. And they haven't really moved much for the whole year. Remember, it was a choice not to extend the subsidies in the tax law, H.R. 1. And Congress has known that these subsidies are expiring all year. State insurance commissioners and other, lobbyists who are not advocates like us have been very clear about their concerns and the consequences. There are some Republicans who do not support the subsidies and are happy to see them expire. There are some who want to extend them, maybe not because they like the subsidies, but because they realize the values to their voting base, and they want to make changes that would make those subsidies less available to more people and maybe not as valuable, right? There are some legislators that are talking about, well, maybe we could do a healthcare package next year. And there are lots of different views, which makes it very hard for them to agree on a plan or any plan. Here's the reality. Monday is the deadline to sign up for ACA coverage if you want coverage starting January 1st. The Senate just voted down the one bill that would extend the current subsidies as they are, and they have not approved any alternative, and they are not in session for the remainder of the week. So that means the Senate is not available to vote on any proposal that the House would decide to pass if, they decided to work the weekend or whatnot. The House has not committed to a vote on extending the current subsidies or even changes to subsidies. And they are not going to be scheduling any votes until next week. Reminder, most people are going to be making decisions before or on Monday, December 15th, about whether or not they are remaining insured or what ACA marketplace plan they are selecting. So, and next week is the last week Congress is in session before they break until 2026. So we're already at the point where if they do an extension, many people have already made decisions. It isn't clear even if they extended the subsidies as they are now, which they have voted against multiple times, how that would work with people who have already selected plans. And it looks very unlikely that that the House will vote next week on extending the subsidies, and that the Senate, even if they did that the Senate would agree. So we really are in a place where the Congress has decided amongst itself that it has in January to fix this, and the reality says something different. Even if they do something in January, they have to also now figure out how do you make people whole who made a decision in this plan year by the deadline, and now now they might have a different might have made a different decision or might get more money back on this on the tax credits. Because health savings accounts keep coming up, and this is an idea that not only has a bill language in the Senate, but also bill language in the House. I'm going to just quickly run through what does this idea mean. And I think it's important for advocates to think about, if this change happened, would it help me or would it not? Would it make things, is it a better value than what we have now? And the bill would, what it would do is let people with only certain kinds of ACA plans have a health savings account. And the federal government would contribute a set amount into that health savings account. And then people could contribute up to a certain set amount to that account. Now, importantly, these accounts are only available to folks with bronze ACA plans or catastrophic plans. Bronze plans cover a much less of the cost of your health care than silver plans. The plan covers 60% and you're responsible for 40% up to a certain level. And generally, your out-of-pocket costs, including deductibles and co-pays, are much higher, but your premiums are low. So if you are a person who maybe doesn't need a lot of health care, you may be able to have a bronze plan, pay lower premiums, and then take the risk that you won't have super high medical bills that you cannot afford because you're responsible for more of the total cost. Catastrophic plans are even less coverage, and they do not have to cover a lot of the things that are required under other ACA marketplace plans. So that's a very different kind of coverage. And the amount of money that the federal government would give somebody who had a bronze plan is divided by age. It's set at $1,000 for people who are 18 to 49 and $1,500 for those who are 50 and 65. Unlike other health savings accounts, the money that's put into those accounts can't be rolled over in another year. That is a provision of this particular bill. So that means that whatever you set aside in that health savings account, if you don't use it in that calendar year, that money goes away. And you set it aside and it's gone. A little bit more about bronze plans. The average deductible is about $7,000. So that's the amount you have to pay before your insurance kicks in at all. The bill also includes some of the Medicaid cuts that were removed from H.R. 1 back in July because they didn't pass the Senate's own rules. Those and there are three Medicaid cuts that were kind of came back in and are included in this bill. Most of them are not applicable to Wisconsin because they impact states that have fully expanded Medicaid, but they were pretty significant in terms of lowering the reimbursement rate for people who are covered under expansion for states. So they were among the changes that advocates in July were removed from the bill because there was a potential for states who expanded Medicaid to lose so much money that they might roll back expansion. There have been a couple of articles about how health savings accounts have worked, largely because, this seems to be a proposal that keeps getting repeated by Republican lawmakers. The other important factor is that money for health savings accounts can't be used to pay premiums. So when you're thinking about the Affordable Care Act marketplace, the subsidies are directly trying to offset premium costs. This HSA idea is not doing that. In fact, it says we're giving you some extra money to pay other things, but not premiums. So if you are a person who maybe can't afford big increases in premiums, or maybe you are thinking about maybe I could do a bronze plan and I could get this new HSA, understand that HSA really won't offset your premiums. The money can't be used for that. And the amount that you can deposit into an HSA is set. So you can start to do some calculations on your own, looking at what the bill proposes and then kind of looking at some of these other resources. If you're a person who, knows what your plan is now, you can start trying to figure out, like, is this a better deal than what the current subsidies are in terms of how much my healthcare plan costs? There's also been some articles about, how health savings accounts have worked as a policy strategy. And the reality is that most people are now in a health insurance plan, if it's employer-sponsored insurance or the marketplace, where they have to pay a lot of money before insurance starts picking up the bill. That's called that deductible. And at the same time, medical prices keep going up. And we've talked before about how it isn't realistic for most people to be able to shop for lower prices because oftentimes, there may not be choices of services, especially who your insurance does or doesn't cover, and that there the prices may be fairly similar anyway. So that has meant that there are many people who have insurance that also have medical debt. Um, and the higher deductibles that you hear about are supposed to encourage people to shop, but it doesn't work because people need specialty care, and we have fewer and fewer care providers or bigger and bigger care providers where there has been less competition. So if you start to hear policymakers talk about, well, health savings account and people need to shop for their services and be good consumers. Only about 7% of the total healthcare spending is estimated to be subject to that kind of intense consumer shopping and decision making. In other words, for 93% of the healthcare that people actually use, shopping isn't a realistic option for them. And when people have plans that are high deductibles, which would be some of those catastrophic plans and the bronze plans that some of these proposals would, steer people towards, that means that there are a lot of people, especially people with chronic health conditions, who end up being in real trouble, and either have to, not get the care that they need because they can't afford to pay for the care, or they're ending up in medical debt. So there's a couple of articles here, and the one from KFF is focused on a person who has diabetes and diabetes management. There's a lot of people who have that, but it is, that story, if you changed out diabetes with another condition that needs to be managed, I think there's a lot of parallels. For folks who are contractors and people who are chronically ill, the expiration of ACA subsidies and the increase in premiums is particularly problematic. Um, Many of the people in the ACA marketplace are self-employed, right? Small businesses, employees, and especially for people with disabilities, they are far more likely to be self-employed than other folks. And that means, and many people with disabilities have existing health issues, and that means that they are at much greater risk of losing either their marketplace coverage altogether because they can't afford it, or having to go down to a plan that doesn't actually provide the coverage they need and may not be accessible to them. Maybe they have a bronze plan, but they can't afford the deductible and the coinsurance, so they still end up, it's almost like they have insurance, but they have insurance that they in fact cannot afford to use. So that's a lot of information for your weekend reading. And if you're inclined to ask Congress some questions, here are some ways to think about what are the new ideas Congress is proposing, and are they a better value or not from what we're doing now? Can you get the same level of coverage that you have for the same price? If the answer is no, what does it mean to have less coverage? Or what, and can you afford a higher price to stay the same? These are the kinds of decision trees that people are doing at their kitchen tables. And it's important for Congress to kind of see the back of napkin math that folks are having to do. If you have to change plans, do you have to pay more if you need to use your insurance? And what does that mean? So maybe you can afford that bronze plan, but can you afford the deductible? Can you afford to pay 40% of whatever the healthcare cost is or not? Can you afford the copays? Those are all questions that directly impact whether or not people can actually use the insurance that they have. And if you have a higher cost plan, does it provide enough coverage for the people who need it? You know, especially with a health savings account, you know, that is a thing where you get a set amount of money that you have to use within that year, but are you allowed to use that money for the things that you need? Can you predict your healthcare costs with certainty to know what you can set aside? Many people who are in the marketplace, especially in Wisconsin, are low-income people. So if you are a person who doesn't have anything at the end of the month to set aside, a health savings account really doesn't help you because you don't have the money to put into the account. And maybe you don't have the money, maybe you can't afford to put that money into the account if you know you can't use it, if you risk losing it by not being able to use it by the end of the year. So that's another back of the napkin math. What's your income? What proportion of your income could you afford to set aside? And the answer might be zero. And what is the amount that you're allowed to set aside? You know, that set number in the statute, plus what the federal government is going to give you. For most people, that's going to be between $5,000 and $7,000. And it can't be used to pay your premium. So if you have expenses that are $5,000 to $7,000 and you can't afford to pay a higher deductible and co-insurance and co-pay rates, and you can afford to pay your premiums, maybe you come out even. If that isn't the case, then you probably are not better off under that new system than you are with the current, what we are doing currently. It's also worthwhile to keep asking the larger questions. You know, not only how would it work out for you as an individual if a specific proposal was put in place, but what do those proposals do anything about rising healthcare costs or some of the other concerns that really impact whether people can choose a doctor or choose services or be able to, you know, to go to the doctor and feel comfortable that they can pay. The other thing that's going on is the federal 2026 appropriation bills. There are 12. 3 of them have passed already, and the other 9, Congress needs to act by January 30th, or we either shut down the government again, or there has to be another continuing resolution passed to keep funding the things that are funded by those 9 appropriation bills. Yesterday, Republican senators were asked, would you be willing to move forward several of those 9 remaining appropriation bills for the full year by the end of this next week? And 2 of the bills that are important to people with disabilities were on that list. But there are some Republicans, and it includes Wisconsin Senator Johnson, who are listed as people who have not committed on or said that they are willing to vote on those appropriation bills next week. Many of the bills that were floated are things where there have been negotiations and there have been some agreements. So, that is going to be important to know whether or not the Senate is going to move forward and act next week on places where they believe they already pretty much agree on spending, or not. Um, if the Senate doesn't vote on the bills next week, that means that's another piece of business that would be delayed until January. And of course, January 30th is the new deadline for either you have a budget in place or you don't. So it would put a lot of pressure on January to get even more work done. And as a reminder, the two bills that we focus on in those appropriation bills have a lot to do. There's the labor, health and human service education budget and transportation housing budget. And both those bills have a lot of things that are funded in them that are really important to people with disabilities. There's also a lot of agreement on the content of those current bills. Both the Senate and the House committees have approved a version of those bills, and they pretty much say we should keep doing many of the things that we're doing now. So, having a permanent 2026 budget in place that really says this is Congress's intent, this is what we want to do, is helpful going into the next year. Many advocates at the national level feel like that is a clear signal and provides a lot more certainty than, say, extending a continuing resolution. The last year, we have seen the administration kind of look at what's in the continuing resolution and then change what they're funding or delay funding or impound funding or other things. So many advocates say there's a real difference between passing a permanent 2026 federal budget bill versus passing a continuing resolution, which gives perhaps the administration the opportunity to continue the pattern of behavior we've seen in the last year. So again, if you need more questions for Congress, they need things to think about over the holidays. Continuing to ask them, hey, are you going to pass a permanent budget? And are you going to commit to the same funding levels for, programs important to people with disabilities? What are you going to do to make sure that the money is spent in the way you intend and gets to the places it's supposed to go? Those continue to be relevant questions into the new year. We have talked several times about changes that the Department of Housing and Urban Development are making that would really shift how we approach homelessness. This is a State Line article that does go into the proposed changes, but really is more focused on what do those changes actually mean in terms of where monies go. And I think that's the important piece that I want to highlight here is that when the federal department makes a change, there are some places that might be disadvantaged to getting money and other places that may have a greater chance of getting more of that money. So there are many places that have had a approach to homelessness, which is, focused on getting people into housing. And the new rules would shift that emphasis and go back to some old techniques of, funding things that are more aligned with enforcement of, disbanding camps, expanding law enforcement activities, and even moving homeless people into kind of centralized institutional settings. We covered that a few weeks ago with, some activities that Utah is planning. There are states who are already doing some of those types of approaches, and they would be rewarded under HUD's new rules because what they're already doing much more is in alignment with what the administration says it wants to spend that money for. So there are several states that are listed in the article: Florida, Georgia, Missouri, Tennessee, and Texas. You'll notice Wisconsin is not on that list, and many other states. And there are also areas that are identified that would be, who currently probably receive a fair amount of money from HUD to do this work, who wouldn't really fit the new criteria. So you can see that there are some places who stand to lose a lot and some places that stand to gain quite a bit, just because the administration is changing how it's deciding to send money out. Now, there's been some developments this week. The notice of funding was posted, and then 90 minutes before a court hearing, which was challenging the changes HUD proposed to make, they withdrew the notice of funding. So, the rule that we've been talking about for several weeks, those changes on how money would be awarded, that seems to be paused. However, we have also seen in a number of programs that a pause doesn't necessarily mean a change in approach. Sometimes it is a pause to figure out how to respond enough and do kind of the spirit of the change in a slightly different way. So HUD has said publicly that we've withdrawn the notice to address the issues that were raised in the court case, and that they will be reposting the notice. I guess we will see when the notice is reposted how much has changed and whether the plaintiffs in the court case feel that it has been changed enough that they no longer have a case. In a similar theme, we've talked several times about that $50 billion fund that was set aside to support rural health initiatives in HR 1. And that was one of the items that was supposed to offset the $1 trillion in Medicaid cuts, which will, disproportionately impact rural healthcare providers. So CMS, all states have submitted applications at this point, and CMS is going to issue awards by the end of this year. It's December 12th. Probably, we only have so many days before the end of the year. 25 billion of that 50 billion is distributed equally across all states, which does give states with small populations more money per person than others. And about a quarter of the money is going to be given out on kind of a formula basis. Again, based on a state's rural population, and other factors that probably reward states with higher rural populations or geographical areas that are rural. But CMS has discretion, total discretion, over 25% of the money. And it seems that how they make decisions on that remaining 25% will be tied to how well states are conforming to a series of policies that the White House favors. There's a lot of concern about how this rural healthcare fund will actually be used anyway. It can't be used for operational costs or other things that perhaps would offset the loss of revenue from people who lose Medicaid or the ACA marketplace. So there was already concern that the projects that would potentially be funded under this $50 billion fund might not, in fact, result either in cost savings or make up for the loss of revenue that is expected for rural hospitals. But now there's also a concern that the criteria that is being used to award a quarter of the money might favor or reward certain states and not others. There's some policies that are on the list that seem to be fairly popular and bipartisan, like expanding telehealth. People like that idea. Okay, so lots of states would probably say, yep, we can commit to that. But there are other policies on the list, including restricting what foods people on like food share can buy with benefits, or kind of encouraging more people to get catastrophic healthcare plans that cover a lot less and also end up putting people in a position where they might not be able to afford their bills. Those are things that lots of states don't support. So none of the policies on the list are really focused on rural residents, and they do impact the entire state. So lots of folks are really watching to see, who gets rewarded in terms of how much money goes where. And there are lots of health experts who are worried that where the money goes might be at expense of, certain rural areas that need a lot of help. The education department this week has called back some of the Office of Civil Rights employees that they have been trying to fire since March. Since March, an ongoing court case has meant that the administration could not proceed with firing those workers, and they had been placed on administrative leave, which means they were getting paid but not working. That court case is ongoing. This week, the department said, we're calling you back specifically to kind of deal with the backlog of civil rights complaints that have accumulated. That doesn't mean that they are not wanting to fire those people. So we're kind of in a limbo situation where, the Department of Ed cut half of its workforce in March, and then many of those workers were fired, but there were about 250 civil rights workers that were placed on administrative leave. Clearly, in the government shutdown, they cut even more workers from that particular section, and those firings have been reversed temporarily. Remember, one of the provisions of the continuing resolution that reopened the government was that folks who had been fired during the government shutdown would at least have job certainty until January 30th. So there's really a lot of people whose fate and future is in unknown at this moment, and a lot of them happen to work in the Office of Civil Rights. So the education department has called some of those folks back temporarily, but they all were clear that the administration continues to support these workers' eventual firings, which, is another flag for disability advocates that, the advocacy and the lawsuits have been important to this point, but we are unclear if that changes the intent, even though these workers are being called back to deal with a huge amount of discrimination cases that have piled up because there haven't been staff that have dealt with them. Also this week, an important vaccine advisory committee has made some changes to the vaccine schedule. And the administration has also issued another memo kind of encouraging a larger review of the childhood vaccine schedule and potentially more revisions to it. So there are a couple of pretty in-depth articles about what these changes could mean. I think it's important for us to talk about it for two reasons. One, people with autism and the idea that vaccines are causal to autism, which has been disproven over the many decades from many different studies, continues to be something that is said by leaders in this administration. And it's being used as a reason for changing the vaccine schedule. Kind of the underlying comments are, if this action causes autism, we don't want to cause autism is the underlying theme. And of course, that raises a lot of questions for people with autism on, whether there's an active, effort to try and prevent them from existing, right? But the other reason that vaccines are pretty important to our population is that a lot of folks are immunocompromised, which means that they rely on everyone else being vaccinated because their immune systems will react. They know that their immune systems will react to a vaccine negatively and that they can't take vaccines. There are people who there is a medical reason why they might not be able to be vaccinated. And so those people really rely on everyone else having those vaccines to limit their exposure to disease. So changes to the vaccine schedule that might result in more people being unvaccinated and a greater likelihood that diseases that could be prevented actually occur, mean that those folks who can't be vaccinated are at a greater risk. And a lot of those people are kids too. So we've been following this fairly closely because an impact is that people who are at higher risk of having a negative outcome from disease are protected when vaccines prevent that disease. And as those protections go away, so increases the risk for people who can't have vaccines. Kaiser Health Foundation put out a really important report this week. And again, this is kind of baseline information about what is it like to wait for home and community-based services. Remember, that's like family care and IRIS and CLTS in Wisconsin. Many states have waiting lists now. This is one of the strategies that we've been talking about all year, that when Medicaid cuts come and, what can states do to control how much they're spending. And so this report is a snapshot about what's happening now before there are $1 trillion in Medicaid cuts that states have to figure out what to do about. We've also talked about home and community-based services being particularly at risk for cuts because they're expensive and they're optional. And we can see already that in states that are facing budget troubles now, this has been where they have gone to make cuts to provider rates. Historically, there's also information about when states have financial trouble. This is a place that they have cut before. So there are 41 states that maintain waiting lists or interest lists for people who want to have help to stay in their homes, to be supported in the community. There's a difference between a waiting list and an interest list. A waiting list is people who are eligible to meet the eligibility criteria to be in the program, but there's just not enough money or spots for them to get in the door. That's the kind of waiting list Wisconsin had, again, not that long ago. Before family care was statewide, we had waiting lists, and it was actually Governor Walker who ended the waiting lists for family care and IRIS. So those are all people who were screened. They met the functional screen. They met the income, the asset test. Yep, you are absolutely eligible to be in the program, but we don't have room for you. So you are on the waiting list. There's also states that don't bother to check whether somebody is eligible or not before adding them to the list. And that's interest lists. And so there are some states that may have 200,000 people who have said, I want to be on this program. And they may look at that list in an order of received, but many of those people on the list may not, in fact, qualify to be on the program, but yet they're in the order. So that's the difference between the two things. There have been more than 500,000 people. In 2025, there were 600,000 people on waiting lists across the country for home and community-based services. And that there are states that are increasing the use of waiting lists now. Most of the people on waiting lists are people with intellectual and developmental disabilities, and they wait a long time. The average is 37 months for people with IDD. It's also the case that waiting lists don't fully reflect how many people need help to live in the community. And this is important because when I say, somebody has been screened and they meet the criteria, remember the criteria of what level of care do you need to qualify to be on the program is different across states. And one of the ways states can save money is to make it harder to meet the criteria. In other words, you might need a greater level of care to qualify to be in the program. That is a way that states can, figure out how they can serve fewer people is by changing, what it takes to get in the program. So a waiting list of people in Tennessee, for example, you could have people waiting in Tennessee who have a higher level of care need than people who are in a program in another state. And it's based on what the state says they want to allow in and how much money they have. So people who would be eligible for home and community-based services in one state might not be at all in another state. And the other piece is that there are, people who are in programs that can't get the services that they are actually entitled for, often because there's a provider shortage or a workforce shortage. A lot of people who are on waiting lists may in fact get some amount of care through different pathways, like personal care, which is on the state plan. But that is an incomplete accounting for how many people need more support than are on the waiting list. Another important article that kind of reinforces some of what we've been talking about the last year. There are lots of states, and Wisconsin is among them, that have made different kinds of tax cuts over the last decade or so. And when you make a tax cut, what you're actually doing is reducing the amount of money that is coming into the state. Tax revenue is a source of income for the state, and then it's the legislature and the governor's job to figure out how do we take all of the money that comes into the state and decide how we spend it on different state functions, like education or prisons or Medicaid or other things. And for people who are low income and rely on a lot of publicly funded programs, the amount of money that comes into the state is important in terms of maintaining the funding for existing programs, doing increases, or, deciding that there are cuts in certain areas and not others. So we are now in a position where states that have reduced the amount of tax revenue coming in are more reliant on federal funding than states that didn't. And they stand to be hurt more by reductions in federal funding that are really contributing to the money that the state has to spend on all of the things that states do. This article goes into a lot of information about SNAP specifically, that there are lots of states that will not have the extra cash lying around to be able to meet the new federal requirements. So we've talked about Wisconsin's legislature has not acted yet to provide an additional $70 million that would keep Wisconsin's error rates low and also provide the extra people and systems needed to do more work and with the same high degree of accuracy. There are lots of states that already have a high error rate, and the amount that they would have to invest to meet the new federal requirements is so much that they might actually not participate in SNAP at all. And that is is not a conversation that's only happening in one state, it's happening in many states. Another win for advocates. North Carolina is the only state that does not have a state budget yet. And this is one of the states that has proposed or made Medicaid cuts in advance of the cuts that are coming from HR 1. In October, they said, hey, we don't have a state budget and we have this shortfall for Medicaid. We have to make cuts now because there isn't any budget. And they decided to make cuts to across the board to a series of providers, including home and community-based providers and institutional providers as of October 1st. And it depended on the provider, but a 3 to 10% reduction was how they were going to close that funding gap. There were some lawsuits, including lawsuits from parents of children with disabilities that said, hey, these rate reductions are actually impacting, doing harm. We think that you can't do this legally. And in under 8 weeks, the impacts of those rate cuts were significant enough that the governor walked back the rate cuts, even though the Medicaid shortfall continues because the state has not yet passed its 2-year budget. So one of the things that is important about this article is what happened in that 8 weeks when those rate cuts were in existence. And it's all the things that we've been talking about will happen, when states have to reduce their Medicaid budgets. Some doctors decided not to take Medicaid patients or additional Medicaid patients. Some providers said I couldn't recruit or train workers because I knew that I had to pay them less. And some providers cut community-based services and supports. They said we can't do the things that we used to do for a reduced amount of money, so we won't do it at all. We'll do something else. And I think the important piece here is that happened in 8 weeks in North Carolina with one change to the Medicaid program. It's a preview of what all states will face as they find that the money they have is not sufficient to continue doing what they're doing now and are exploring different ways to cut. If they're making cuts to Medicaid, there are real impacts that happen very quickly for even when the state isn't changing, the eligibility, like who can get in and stay in Medicaid. That doesn't mean that people who are in aren't going to feel impacts when other budget items are cut. This is an opinion piece, but it is written by a person with a disability. And I think it does have some good language if you are looking for, how to frame talking about certain issues. And it does kind of frame how we are thinking about work requirements, and why we think work should be tied to healthcare at all. California is also looking at, what will the impact of HR 1 be? This is particularly focused on parents of children with disabilities. And I think that the takeaway from this article that's important is when you're thinking about a state budget, it is all the things that the state provides money for that could be impacted from big reductions in the budget. So if there is a lot less money, federal money coming in for SNAP and for Medicaid, that leads to huge budget holes that impact other programs that aren't those big spending items. And in California, the connection that's being made in this article is, Medicaid is used in schools a lot. So, if we're cutting Medicaid, it might mean that parents and families are losing supports that are really critical and important to keeping their kids at home and out of an institution, but it also may have impacts in other parts of their life because Medicaid is used to fund so many things. With that, I am going to stop sharing.